What's up, Ninja Nerds? In this video today, we're going to be talking about acute liver failure. This is a part of our clinical medicine section. And if you guys like this video, please support us. And the ways that you can do that is by hitting that like button, commenting down in the comment section, and please subscribe. Also, if you guys get an opportunity, I highly suggest you guys do this. Please go down in the description box below. There's a link to our website. On our website, we have a lot of really cool things to offer there. Some great notes, some great illustrations. We're developing quiz questions, as well as a lot of exam prep courses, a lot of things that are coming there. So please go check that out if you have the opportunity. All right, let's talk a little bit about acute liver failure. So what is it? Acute liver failure is when the liver decides to fail. It takes a crap and it decides, okay, I'm not going to no longer produce things. I'm no longer going to filter things as I should be doing, but it develops acutely, abruptly. Usually we use this term, time frame that's ambiguous, but less than kind of like 26 weeks. And then on top of that, the most important point is that acute liver failure is the liver fails acutely without a history of underlying liver disease. That's really the big thing. And that's what's really important to kind of differentiate between something like cirrhosis. So cirrhosis is the liver has chronic liver injury. It's repeated liver injury, usually underlying liver disease that progresses over time. It's more than 26 weeks. And that's one of the big differences here. Now, with that being said, what's really causing the liver to become injured and lose its synthetic and filtering function? That's a great question. And I think one of the best ways to kind of phenotype that is based upon this concept. Is it a direct parenchymal hepatocyte injury, or is it a indirect, in other words, it's vascular related parenchymal injury? So let's talk about that a little bit more. Here's the liver. We take a piece of the liver, one little cell called a hepatocyte, and zoom in on it. When I injure this liver, so a patient experiences some type of liver injury, generally when there's massive liver death, liver cell death, hepatocyte death, it causes a massive inflammatory reaction. And usually the liver, if it has enough time, it compensates and regenerates. That's one of the beautiful things about the liver. But if it occurs massively, acutely, without the time for it to be able to compensate and regenerate, that's what will precipitate the terrible findings that we see in acute liver failure. But the question is what's causing the injury itself. So what's directly hitting these liver cells, causing them to become damaged? And you know what's one of the cool things is that whenever a liver cell is damaged, it really signals that there's something wrong via particular lab markers. And some of those lab markers that leak out of the cell as a result, they'll be elevated on laboratory studies that we'll talk about a little bit later. And some of you guys will probably know these. What are some of these things? This could be things like AST. This could be things like ALT. And this could be things like your bilirubin. And this could be various types. This could be actually a mixture. It could be unconjugated and conjugated bilirubin. But either way, they're all going to be elevated. Now, this is a marker of liver injury, right? But we'll talk a little bit later about things that actually are more indicative of liver function, like albumin production, and more other things like coagulation protein production, or a filtering of things like ammonia and other kind of like bacteria and toxins. But if there's an injury to the liver, what's the causes? And really it comes down to a couple different things here. One is drug induced, and I don't want to go too crazy and list every single cause. I want you to focus on the biggest ones. And usually the most common one is going to be Tylenol or acetaminophen. So Tylenol toxicity is going to be something that you'll see whenever a patient is taking more than 4 grams of Tylenol per day. Generally, if you take less than 4 grams per day, where you're within that or at least 4 grams per day, you're within that normal recommended daily allowance. But if you go way above that, higher chance of causing a lot of Tylenol toxicity, and thus drug-induced liver injury, we call DILI. Second one is it could be viral induced. And there's a bunch of different viruses, hepatotropic viruses, there's so many. I think the biggest ones to be able to remember is your hepatitis A virus, your hepatitis B virus, your hepatitis C virus, your hepatitis E virus. Usually these hepatotropic viruses are going to be by far the most common. I'd say out of these, I'd say hepatitis A and hepatitis E are probably more of the acute type, whereas hepatitis B and hepatitis C, they can cause acute liver failure, but they're more likely to cause more of the cirrhosis type of picture. You can also see these in patients who have herpes simplex virus and potentially CMV, but this is more in like immunocompromised patients. So think about this. This is a potential. If a patient is having things like this, they've had potential dirty needle or blood exposure or seminal fluid exposure, something like that, or they've had some dirty food, they had some food from like a food truck that probably wasn't cooked properly, or they were traveling. These are potential things that could be more of a source, especially in the clinical vignette, that would suggest hepatitis viruses. All right, what's another one? Another one, this one's actually really difficult to differentiate. It's called antibody mediated. We also call this autoimmune hepatitis. So autoimmune hepatitis is kind of tough to diagnose. It's usually kind of lower in the food chain. So when you think about this one, you'll see a patient who have massively elevated ASTs and ALTs. They won't all the time present with this classic like joint pain or rashes or anything like that. Oftentimes they'll have massively elevated ASTs, ALTs, and bilirubin, and you'll send off antibodies that are the source of this cause. And generally there's so many of them. But I think the biggest ones that you'll send generally are gonna be things like ANA, so anti-nuclear antibody, anti-smooth muscle antibody, IgG, usually the soluble type, and there is another one called anti-liver kidney microsomal 1 antibodies, but I'd say these are gonna be by far the most important ones, and they're indicative of antibody-mediated damage. Okay, so you'll send off viral panels, you'll send off a Tylenol level, you'll send off antibody levels. The last one's a little bit more tough, but when I say it's tough, it's not really a lab value, it's more of a clinical history that you're gonna be picking this up on. A patient is usually pregnant, usually 3rd trimester. They're showing features of preeclampsia, hypertension, proteinuria. And if they also show signs of acute liver failure, such as, well, we'll talk about a little bit later, white upper quadrant pain, jaundice, hepatic encephalopathy, coagulopathy, etc., then you want to think about what's called, we usually use the kind of the abbreviation here, acute fatty infiltration of the liver during pregnancy. This is usually something that will happen again in patients who exhibit features of preeclampsia. So you really want to look for that within the history. 3rd trimester, hypertension, proteinuria, and then now features of liver dysfunction. Usually the pathophysiology behind this is that they don't break down fatty acids, so they don't undergo beta oxidation, and those fats build up within the liver and cause massive steatosis. All right, that's this concept of direct liver injury that causes these levels to fly off the handle. But what if it's not direct injury to the parenchymal cells by drugs, by viruses, by antibodies, or by fatty infiltration from beta oxidation dysfunction? What if it's the vessels that in some way, shape, or form are diseased or not delivering what they're supposed to? This is the artery, the hepatic artery. So we'll say this is the hepatic artery. Its design is to deliver, son of a gun, its design is to deliver oxygen-rich blood to the actual liver cells. That's its job. It'll drop off oxygen. This is the hepatic vein. It's supposed to be able to remove waste products. Generally, well, anything that comes through the liver, it actually gets cleansed, but it'll take blood from the liver that's gotten cleansed, removed of toxins, removed of bacteria, and then it'll put it back into the systemic circulation. If there's disease of these, and you're not allowing for these arterial or venous systems to work properly, the liver can either not get oxygen or it can become congested. If that happens, the liver will then become injured. If it becomes injured, one of the things that is usually a sign of liver injury is elevated ASTs, ALT, and bilirubin. And then the downstream negative consequences of having acute liver failure, which we'll talk about, is the complications of the loss of synthetic function and filtering function. But this is what we'll potentially see here with respect to the lab values that suggest liver injury. Now, if you think about it, here's the aorta, here's the hepatic artery. What's the problem here that could be causing oxygen not be delivered to the liver cells? And the concept behind this is the patient is developing something called ischemic hepatitis. And it is literally what the name says. A patient is developing inflammation of the liver because of ischemia. What could be the cause? It's usually shock. And the primary way that you identify this is that the patient will have profoundly low blood pressures. So blood pressures will be in the turd, they'll be in the tank, they're not gonna be good. And because of that, if my heart, let's say I have cardiogenic shock, is not generating good cardiac output, obstructive shock, can't get blood out of the heart, hypovolemic shock, don't have the volume to deliver the blood to the tissues, or septic shock, my blood vessels are dilated and there's no resistance, and again, I'm not generating a pressure, I'm not perfusing the tissues. That's the concept here, is that the blood that's supposed to be circulating through here and dropping it off to the tissue cells, let's say here is gonna be a couple hepatocytes, they're supposed to be receiving oxygen, which is dependent upon the blood pressure. If the blood pressure's in the tank, you're not gonna perfuse these tissues. If you don't give them oxygen, they will become ischemic and they'll start to die, and that's what you're gonna see as a result. Okay, the other concept is what if it's actually from the vein? So The venous one is twofold. It could either be due to, one is if you get really, really deep down here and you look at this, look, there's a clot within the hepatic veins, right? So if you have hepatic vein clots, all right, so hepatic vein clots. This is usually due to a disease called Budd-Chiari syndrome. And this is when you have a bunch of clots of the hepatic veins. If there's clots within the hepatic veins, what's supposed to happen is I'm supposed to take blood that's coming from these liver cells, move it through these hepatic veins into the inferior vena cava, and then into the systemic circulation eventually. But if this is being impeded at this point, am I going to get blood through there? No. The liver cells will then become congested, injured. We got the point. So think about this. Usually in a patient who has liver cancer, hepatocellular carcinoma, they have malignancy, anything that makes them hypercoagulable, so underlying like hypercoagulable condition, like gene mutations, like factor V Leiden or prothrombin genes or antiphospholipid or anything to that effect that makes them hypercoagulable, polycythemia, these are really big things to see in the vignette that would suggest this. Lastly, is that maybe it's a little bit further, more distally, where the inferior vena cava is being congested because this process where blood is supposed to be entering into the right heart is impaired. If that's impaired, it's because the right heart sucks and it's not doing its job. So this would be what we call hepatic vein congestion. So what if the hepatic vein is congested with blood because it can't allow for that blood to go to the inferior vena cava into the right heart because the right heart is all jacked up? This would be in a scenario of right heart failure. If a patient has right heart failure, like terrible constrictive pericarditis, it could potentially cause their liver to become super congested and can cause acute liver failure. Oftentimes with these, it's about looking for the history of right heart failure, doing an echocardiogram, considering doing an ultrasound or Doppler ultrasound of the actual liver veins and looking for the actual clots there. And then looking in the context that a patient just have terrible blood pressure. These are ways that we can use just to think about a patient having some type of acute liver failure. I think one of the biggest things to remember is when a patient comes in with acute liver failure, they don't say, hey, my liver's jacked up, dude. They're gonna come in with some very subtle signs. And I think one of those big ones to think about is when the liver's really inflamed because of injury, it stretches on that Gleason's capsule, which is actually kind of innervated and creates this pain where the liver sits, the right upper quadrant. So look for right upper quadrant pain. But you know what's a really big sign? It's related to this bili. Here, I'll asterisk it for you. If the bili's elevated, you know where this likes to go and deposit? It loves to deposit in the sclera. And when it deposits into the sclera, it actually causes a yellowish discoloration, icterus. It can also deposit into the skin all over the place, and it can cause jaundice appearance. So in a patient who comes in jaundiced, you really want to think about acute liver failure, especially if they have no underlying history of liver disease and it's developed acutely or abruptly less than 26 weeks. Now let's talk about the complications. All right, my friends, so now we have a patient comes in, acute liver failure. They're showing signs of right upper quadrant pain. Maybe they're showing signs of icterus or yellowish discoloration that would suggest jaundice. We're thinking, oh, maybe something's wrong with the liver. We think, okay, what could be the causes? It could be Tylenol toxicity, it could be viral, it could be autoimmune, could be pregnancy related. I got to think through my clinical history in the scenario. Could be vascular related. Are they in shock? Do they have right heart failure? Is there suggestion of hypercoagulable state in Budd-Chiari syndrome? All those thoughts are going on in my mind. But the thing that you should also be understanding is that yes, okay, I'm going to work up the patient, see if they do fit the acute liver failure category, work up the cause, which one's the likely cause. But you want to be watching out for other complications because acute liver failure is not just defined as the liver's failing, you have markers of liver injury. We really define it off of a liver that's actually, again, failing without underlying history of liver disease, very abruptly, and we use two other very specific categories. They have encephalopathy and coagulopathy. And we'll add on two other things that are important and can be helpful, but aren't absolutely necessary in the diagnosis. These are the two big hitters that you have to remember for acute liver failure. You can have big elevated liver enzymes, but you need these things as well to call it acute liver failure. So what the heck is hepatic encephalopathy? The concept behind this, and we'll go over what the patient will look like in a second, is they have to have underlying liver dysfunction. You can see this in cirrhosis and you can see this in acute liver failure. But the liver is injured in some way, shape, or form, and there is dysfunction. Normally, let's say here's the gut. Coming via the gut, you have the portal vein, right? So this is going to be coming from the gut. Coming from the gut, you're going to have a bunch of different things. But often, sometimes, one of these molecules that we love to use is is the example of encephalopathy is called ammonia. We'll use NH3 as that molecule. Now, ammonia, when it comes from the gut, it goes via the portal vein. When it goes via the portal vein, it goes into the liver, and it's supposed to be metabolized. It'll be metabolized by the liver. You can also have it coming from other ways too. It can be coming from muscle tissue via the arterial system to the liver. Either way, ammonia is supposed to be metabolized by the liver. But if the liver has injury or dysfunction, is it going to be able to clear that ammonia very well? No. And so what happens is this clearance of ammonia doesn't occur very well. And so what ends up happening is whenever the blood leaves the liver, goes via the hepatic veins and enters into the systemic circulation, guess what happens? It doesn't get cleared. It's supposed to be broken down into urea. That doesn't happen. And so these ammonia levels, as a result, build and build, right? Because this process here where you're supposed to clear it is not occurring. There's damage, there's dysfunction. And so ammonia will not be cleared. It'll build up within the systemic circulation. Now what we know is that ammonia loves the brain. It loves like the astrocytes of the brain. And what happens is it goes and it actually gets taken up by these astrocytes in the brain. When they get taken up by the astrocytes, they actually, specifically, they'll bind on to an amino acid called, it'll bind onto like glutamate and convert into glutamine, and glutamine is really kind of like osmotic, and it'll pull water into the cells. This will also kind of like alter some of the activity of the neurons just in general. And so what can happen is two particular things as a result of this ammonia building up in the actual brain cells. One is it can cause cerebral edema. And this is the terrifying, super scary, sphincter pinching kind of thing that you just don't want to see in these patients is cerebral edema. Why? What does cerebral edema do? It'll cause the brain to start swelling. The skull's a fixed space. The Monroe-Kelly doctrine tells us that. So because of that, what happens to the intracranial pressure as a result? It can increase. And so what we could see as a result is that we could see these patients developing elevated intracranial pressures. And sometimes we actually use monitors to do that in patients with severe acute liver failure and elevated intracranial pressures secondary to cerebral edema, because that's the ammonia that's causing this problem. The ammonia will really lead to this situation here. Now, the other thing here is when you cause dysfunction in these neurons, not only will they swell, but you could also lead to two other particular findings. One is these patients can develop what's called an altered mental status. We often use the kind of abbreviation AMS. That's one. You know what else? Here's the key term, asterixis. It's kind of like this weird flapping tremor, if you will. So if a patient presents with confusion, hallucinations, insomnia, lethargy, stupor, coma, agitation, all of these particular things, we can consider that altered mental status. And if they have a flapping tremor, you extend their hands and it kind of flaps back, that's indicative of asterixis. And then if you by some way got a CT scan or used particular measurements of being able to quantify intracranial pressure, it would be elevated because of the edema factor. All of this is due to the liver not being able to metabolize the ammonia, not being able to filter it and clear it properly. So this is really where the issue arises, is that the ammonia will then cause brain dysfunction leading to this encephalopathy factor. So when a patient comes in with acute liver failure, look at their degree of mental status. Are they confused, delirious? Are they not making sense? Are they agitated? Are they sleepy, lethargic, comatose? Look for all of those findings. Do they have asterixis? These are big things to look out for. Now, encephalopathy and acute liver failure, sure, can happen on its own, but oftentimes there's precipitants that kind of increase the ammonia in general, whether it's increasing the absorption, decreasing the clearance. So not only is it in the setting of acute liver failure by itself, but it can be, let's say, agitated or precipitated. So we can say that this can be precipitated by a couple other factors, such as what? Sometimes it could be precipitated by infections like SBP, so it's called spontaneous bacterial peritonitis. It can be exacerbated by GI bleeds. It can be exacerbated by renal failure where you can't clear the ammonia. And so I think it's important to realize that, or dehydration. These are important things to consider as a trigger. So this can be precipitated by infections like SPP, GI bleed, renal failure, hypovolemia. In the setting of liver dysfunction, acute liver failure. Okay, we have a patient, confused, altered, asterixis, potentially cerebral edema, elevated intracranial pressure. That's one finding. The second one is they have to have a coagulopathy as well. So coagulopathy is, again, the liver's jacked up, it's not working. And if it's all messed up, one of the other functions of the liver, not just to clear, is clear ammonia. You know what else it does? It makes clotting proteins. So it's supposed to synthesize these clotting proteins. It puts it into the bloodstream. And these will circulate through the bloodstream, and they're very important clotting proteins. There's so many of them that it makes. It makes things like factor 2, factor 7, factor 9, and factor 10. And all of these are important because these are procoagulants, meaning they want to induce clotting. It'll also make some other ones like protein C and protein S, but those are anticoagulants. They want to prevent clotting. Here's the problem. Whenever your liver fails, you fail to produce these procoagulants. And to a degree, yes, the anticoagulants, but these are the ones I want you to focus on. If I can't produce these procoagulants, let's write that down. Procoagulants. Can I induce clotting? No. And as a result, I'll have decreased clotting that occurs. If I have decreased clotting, obviously as a result, there's increased risk of bleeding. And how can bleeding present? Well, in these patients, it can look a lot of different ways, but oftentimes it can be from, let's say, from most terrifying to least terrifying. One way is you can literally bleed into the brain. I see this a lot working in a neurocritical care. You see this as intracranial hemorrhages. This is a really, really terrifying one, probably the one with the highest mortality rate. You can see bleeds from the GI tract. So GI bleeds would be another particular one that you want to watch out for. So watch out for ICH, watch out for GI bleeds. And the ones that I think would be the least scary, but they still can occur, is like epistaxis, gingival bleeding, or anything around the skin. So lots of bruising and petechiae. So look for mucocutaneous bleeding, we call this, mucocutaneous bleeding. And this could literally be as simple as like them having multiple bruises and petechial lesions. So that's a really important one. But here's the other thing. Factor 7 is the really big one, because what's interesting is it's one of those procoagulants that gives us an idea of what we call the INR, the International Normalized Ratio, which is a lab value that we use a lot. So ammonia is one of those that we use as a lab value. We can look for that. Well, we really prefer the exam in the setting of acute liver failure. But off this one, it's hard to like measure all of these. So what we do is we use one of those, which is a better measurement. And so you'll have decreased clotting. And so what we do is we can actually say that if there's less of these, very specifically factor 7, it will actually do what? It'll increase the bleeding time. And one of those is via the INR. So the INR, sometimes we also say PT. Let's actually write that down. PT INR. So the PT INR will be elevated, and this is indicative, very specifically, that there's something going on with factor 7, which is a product that is produced by the liver. That's really, really important. Okay, in the patient who has failing liver, massively elevated liver markers, they also have jaundice, right upper quadrant pain, confusion, asterixis, and an elevated INR. Usually greater than 1.5, some will say 1.6, then I'm really thinking it's acute liver failure. Other things that would add to the supporting nature that it's acute liver failure is obviously going through the diagnostic tests and finding the cause, but other things would be hypoglycemia. So the concept behind this is that the liver is failing. It's losing its ability to perform its natural functions. One of them is to perform something called glycogenolysis and gluconeogenesis. If the liver's jacked up, can you do that? Do you have enzymes that are capable of helping that process? No. So gluconeogenesis is impaired, and glycogenolysis is impaired. If that's the case, this is supposed to form new glucose from non-carbohydrate and break down glycogen into glucose, putting it into the bloodstream. So it's supposed to take from the liver and put, which I'll represent as these kind of like black dots here, glucose molecules. But if you can't do this process here, what's going to happen to the glucose molecules within the bloodstream? It's not going to go into the bloodstream because I can't do these. And so you'll have a patient with hypoglycemia, very low blood glucose levels. So look for hypoglycemia and elevated INR, generally like greater than 1.5, and elevated ammonia, or usually evidence of confusion or encephalopathy with asterixis. All right, so the last thing that I want you guys to watch out for is infection risk is really high in patients with acute liver failure. It's a couple of reasons why. One is inside the liver. So the liver's all jacked up, and so that means that not only is the liver cells injured, but some of the other cells that are associated with the liver cells around it, such as these cells here, are also injured and dysfunctional. And this includes these like little liver cells, these macrophages that sit within the liver, and they're called Kupffer cells. They're like little macrophages. And so what happens is, imagine bacteria. Here's some bacteria or some fungi or different things like that. They're coming from the gut. And naturally what happens is if it does make it to the liver will have Kupffer cells that will destroy these little suckers, prevent them from getting into the bloodstream. The other concept is that you have these other molecules that your liver releases. And so it makes these other molecules here called complement proteins. So we'll put here, I'm just going to say that there's these molecules here called complement proteins. And these are really helpful in breaking down, or at least increasing inflammation and helping to break down bacteria. In patients who have acute liver failure, they have decreased complement proteins and decreased Kupffer cells, which means that they have a decreased ability to clear bacteria. So that means that tons and tons of bacteria that should not generally be making it through the liver and getting into the systemic circulation do. If this happens, and they get lots of these bacteria into the bloodstream, what are they going to do? They're going to go to your respiratory tract. This is the three sites that they love: the respiratory tract, the urinary tract, and they like to stay in the blood. And if this happens, it can cause pneumonia, it can cause a UTI, or it can cause sepsis. And so that's the concept here. You can get a patient who develops pneumonia, they can develop a urinary tract infection, or they can potentially develop sepsis and even high risk of septic shock. That's the scary thing about this one. All right, that covers the complications of acute liver failure. Now, if I have a patient who comes in, abrupt failure of the liver, massively elevated LFTs, AST, ALT, bilirubin, jaundice, right upper quadrant pain, work up the causes, then think, do they have encephalopathy and an elevated INR? If they do, I have a diagnosis of acute liver failure. Think about these two to watch out for scary, scary complications and to add to the diagnosis. Now, let's talk about the diagnostics. I think a patient has acute liver failure. I need to have what? Well, first I need to have liver injury, severe liver injury. So I'm going to get some LFTs. I'm going to look at those AST and ALT molecules. Are they super elevated, at least greater than 1,000? Yeah, that definitely supports hepatocellular injury. And then I would think about some of the causes here in a second, but let's at least diagnose acute liver failure. Do they have features of encephalopathy? So in other words, do they have confusion? Maybe they have loss of consciousness in the form of lethargy, maybe obtunded, maybe they're comatose. Do they even have cerebral edema? Well, I can obtain a pneumonia, but I don't need a pneumonia. So if a pneumonia is elevated, okay, cool. That definitely helps me suspect that they may have acute liver failure with encephalopathy, but it doesn't exclude it, all right? The next thing is, do they have features of coagulopathy? In other words, are they not producing an adequate amount of factor 2, 7, 9, 10? What does that actually help me with? The PT-INR. This is the lab value. If they have less procoagulants, they'll take a longer time to clot. So their PT, their prothrombin time, will be very long, or high, if you will. And so if their PT-INR is elevated, at least greater than 1.5, that suggests a coagulopathy. So if they have a hepatocellular injury in combination with encephalopathy and coagulopathy, we definitely have acute liver failure. Then you have to just start thinking about what are the causes. Do they have an accidental ingestion or a purposeful ingestion? Maybe check a Tylenol level to rule out DILI. Do they have any potential risk of having hepatitis? Check the viral serologies, hepatitis A, B, E, and I wouldn't really waste your time potentially on C, but you can if you'd like. The other one is get a liver ultrasound with Doppler to look to see if they have any Budd-Chiari syndrome. And then also you could do an ANA and an anti-smooth muscle antibody to rule out any type of autoimmune hepatitis. You could also get an echocardiogram to rule out right heart failure, and then also look at their history to see if they have any recent events of a profound hypotension, shock, or cardiac arrest, which may suggest ischemic hepatitis. All right, we've talked about liver failure and acute liver failure. How do we treat it? Well, unfortunately, the damage has already been done to the liver. Your job is trying to at least prevent complications, such as them continuing to have profound and fulminant hepatic failure. So you can try your best to try to reverse the underlying cause. But a lot of the times that may be very difficult because you're trying to find the cause when this patient is very, very sick. So a lot of the times, one of the first things that's usually mentioned is, do they have any Tylenol toxicity? If there is a drug that has been shown to reduce mortality in Tylenol toxicity related to acute liver failure, and that drug is called IV N-acetylcysteine, also referred to as NAC. The mechanism by how this works is not completely clear, but it's been shown to really reduce a lot of the inflammation and potentially reduce the risk of profound fulminant hepatic failure and the need for transplant. And that's a really significant mortality benefit. There is some data to suggest that even if it is not related to Tylenol toxicity, you should still use this drug either way in any other cause of ALF, acute liver failure, even if it's not Tylenol toxicity. But do remember that it's more beneficial, and the studies suggested it to be more mortality benefit related for Tylenol toxicity. Oftentimes, unfortunately, with these patients, you're going to support them the best that you can to allow the liver to heal, but oftentimes they may progress to needing a liver transplant. Encephalopathy, we're trying to reduce a lot of that ammonia. And so a couple different ways that we can do that is by giving them something called lactulose and potentially rifaximin if they need it. And then if they have really high intracranial pressure, oftentimes you'll try to treat them with things like hypertonic saline and mannitol, but we'll talk about that more in the neurology section. Let's focus a little bit on the lactulose or the rifaximin more particularly, because these are common agents that are used in acute liver failure and cirrhosis. Lactulose being the first one, what we do is we give this drug, it's ingested, and what it does is it acts on these bacteria, particularly in the colon, and helps by specifically do something really interesting. It increases like this lactulose, so it leads to like a lot of lactic acid and acetic acid production from the bacteria. The bacteria break down the lactulose, make a lot of lactic acid, acetic acid. Why is that helpful? What happens is these guys release a proton off of them. That proton binds with the ammonia that may be present within the actual bowels, converts it into ammonium, which is not really going to be absorbed as easily. It's less toxic and allow for it to be excreted into the feces. And so that's one way that we can drop the ammonia levels and reduce the actual trigger, which we believe is ammonia, that's causing the encephalopathy, the asterixis, the cerebral edema. Rifaximin has just been shown to destroy some of the bacteria in the colon. And if you destroy some of the bacteria in the colon, you may reduce a little bit of that ammonia production in general. So that's the concept there. What about the coagulopathy? Oftentimes, it's usually going to be giving something like FFP and sometimes vitamin K. The concept behind this is that your liver's pretty damaged, but maybe you have some residual liver cells that are actually healthy. The vitamin K will stimulate those remaining residual healthy liver cells to produce lots of factors 2, 7, 9, and 10. So you get more procoagulants. FFP or PCC will literally replete the actual factors 2, 7, 9, and 10. So either you're making more or you're just replacing them in a solution. When I get more of these, I get more procoagulants, and I allow for me, if I have a hole or tear in a blood vessel, for me to repair that hole and lead to a clot there, which reduces the risk of bleeding. This is oftentimes can be given usually before procedures, or if they have any complications such as an intracranial hemorrhage, maybe a GI bleed, or lots of mucocutaneous bleeding. Hypoglycemia, it's actually relatively simple. You're just going to give them dextrose. The other thing is reducing infection risk. You do not start these patients on antibiotics, but have a low threshold to start them on antibiotics if they develop a fever, a profound leukocytosis, or anything that makes you think that they are very likely to have an infection such as sepsis or pneumonia. My friends, that talks about everything that we need to know about acute liver failure. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.